All right. Well, it's so wonderful to be with y'all today. Thank y'all so much for your patience for those of you who may have been registered for the class yesterday and were not able to host the class yesterday because of a conflict with my nursing schedule. We certainly appreciate your flexibility. For those of you who may have joined because the class time did change, I'm glad that y'all were able to make it as well. We always want to make this convenient and really meaningful experience for y'all. So we're going to be talking about diverse populations and health equity. And this is always an important topic, certainly one that as a nurse, I am very passionate about. So my name is Abby Horton. I teach in the Capstone College of Nursing here at the University of Alabama. I'm a registered nurse. I'm a certified health and life coach, which is why I'm here with you today. I'm a Well-Being ambassador for the Honors College where I teach part-time, and I am your wellness class educator. My email is abby.horton@ua.edu. And if you have questions or want to reach out, please feel free to do so. I know sometimes we think of questions or we want to ask about a specific question or topic, and it's just easier to do that one-to-one. So you're welcome to reach out to me in that way. We will also have time for a Q&A at the end. I see how discrepancies in healthcare can be addressed for different populations is another one that I saw in the Q&A. So yes, we'll talk about that. So today we're going to talk about common health concerns among different populations, identifying barriers to health equity, which can certainly impact all of us, right? We all have a way that we are diverse. We're going to talk about solutions to overcoming some of those barriers to health equity. We're going to address some needed policy and cultural changes, and then also provide some resources and tools to promote health. Both things that you can do here on campus through our employee benefits, and then also in the community. So I'm excited about sharing some of this information with you. So I want to really start our time together talking about bioindividuality. And so when we think about health equity, when we think about diverse populations, the thing is that rather than focusing on one vulnerable group or focusing on one particular population, what I really want us to think about is bioindividuality. And for every one of us on the call, and we have a good number in the group today, there are going to be things about us that make us different from one another. We're not all the same. Even in our own families, you can think about how different we are from our siblings or our parents or our cousins or grandparents. And so the thing is even though we may belong to a particular group, a vulnerable group, that doesn't mean that we have to address everything from a group mentality, because even within that group of people, there's going to be diversity, and we should celebrate that. Unfortunately, medicine and healthcare and kind of our medical model hasn't always accounted for that individuality. And the research that has been done has largely been done on healthy, middle-aged, Caucasian, usually European descent males who, are going to have a different metabolism, are going to have different genetics, are going to have different environmental factors and things at play than someone who's a woman, or someone who's older, or someone who isn't as healthy as a baseline, or for someone who is of a different ethnicity. And so it's just important that when we think about the folks that are being recruited for research in medicine and the folks that are doing research sometimes don't account for that bioindividuality. And I'm really proud to say that we're starting to see a change in that. But when we think about how metabolism of medicines happen, or how certain treatments or therapies are developed, they're developed on a really small subset of our population. And so it doesn't always work when we give that medication to someone of a different group, of a different characteristics and things. And so I just want us to think about this notion of bioindividuality, and that for everyone in the world, if we all on this call, I think there's 22 of us. If all 22 of us have hypertension, have 3 or more readings of high blood pressure, you get a hypertension diagnosis. all of us would respond differently to the medications and the treatment that would be given. And typically, that's going to be hydrochlorothiazide and lisinopril. And we know that for most people, particularly if you're of African descent, so African American, you're not going to respond as well to what is the standard treatment of hydrochlorothiazide and lisinopril. That doesn't mean that it wouldn't work for you personally, but we just know research shows that it's not usually the best option for that particular subpopulation. And so it's things like that, creating awareness, having those conversations, not only in healthcare, among healthcare professionals like me and my colleagues, but among the general population, so that you know to ask those good questions and to advocate for yourselves. And so many of you put to advocate for others. So bioindividuality is the idea that there's not a one-size-fits-all approach to health or nutrition or really anything in healthcare or in life, and that we're all unique, that we all have unique biological makeups and requirements, and that each person has their own specific nutritive and health needs, as well as routines, practices, preferences that work for them. And that's so important, that sometimes things work well for a patient or a client, but that doesn't mean that it meets their need in terms of their lifestyle or their preference. So that's an important component. So types of diversity, we often think about and talk about race and ethnicity. And race, well, we're not going to go into the construct of that, but race is really more of a construct, a social construct that we have put together in society. Ethnicity really looks more at our cultural, geographic, and genetic backgrounds. And so ethnicity is usually more of the preferred way to look at that difference. Certainly gender, male and female, and then we know that there is a spectrum with gender, sexual orientation, age, certainly, 20s, 30s, 40s, that seems to be the age that really is targeted in research. We know that younger folks and folks older than that, older than middle age, can experience discrimination, and ageism is an issue. Young people can be discriminated against as well. So there's that concern. Cultural background differences, misunderstandings of cultural backgrounds. We've always talked about in healthcare having cultural competence, but now what we're talking more about is having cultural humility, and meaning that we are always learning. That cultural competence approach has more of this: take a workshop, take a webinar, get a certificate, and be competent at cultural understanding. And cultural humility is more what we're focusing on now, where we're focusing on, how do I meet the needs of the person in front of me, and what is best for them, because everyone in a religious group or a cultural group is not going to believe the same or have the same needs. And so it's making sure that we don't, put that, lens on when we're looking at someone and only see them as their culture or their religion, because we certainly know that not all, people from a certain group believe the same way or have the same needs. Educational background can be important, especially with health literacy. When we look at overall literacy rates in the US, we know that there's, depending on the metrics that you use, anywhere from a 6th to a 9th grade reading level in the US. And most of our health brochures and our education is at a higher level. And so we really have been charged with making sure that health promotion materials and things that are given to patients or given to clients are actually at a 5th or 6th grade reading level. And the problem with that is it's trying to make things more accessible to a broader audience. But then if you have folks who are well educated, they may not get the level of detail that they need. And so really providing educational materials at multiple levels is where we're really moving toward in health literacy, so that we do support all learning. Because if you do have someone who has a college degree or who has more of a deeper level understanding, and you give them information at a 5th or 6th grade level, that can be as harmful as giving the college level literacy materials to someone who only has a 5th or 6th grade reading level. And then we have to really think about, how often do we even assess the literacy level of the folks that we're taking care of? And then socioeconomic resources, certainly there is a level of classism that happens in healthcare and in our broader culture. And so for those who don't have the socioeconomic resources, they may have the education, they may not have any of the other diverse, aspects to their lives that, we've listed here, and there's certainly many more, but maybe they just don't have resources. Maybe it's a job loss, certainly post or kind of peri-pandemic, we have a lot of folks who don't have that financial stability or may not have access to the resources that they had before. Maybe things have closed in their communities. We certainly are seeing that in rural areas. And so there may be some disconnections between the socioeconomic resources that the folks have and what their needs are. So closing these gaps and really celebrating diversity, celebrating bioindividuality is really the purpose of the talk today. So I'm going to show you all a brief video. We used to show this in our classroom when we did these in person. And so it's been a while since I have done this on Zoom and shared a video, and there's usually some tech issues, but hopefully it's going to work well. I really believe in amplifying the voices of the people from populations that maybe don't get to voice, their point of view. And certainly I'm just one perspective, and recognizing my privilege in that, I want to give an opportunity for you to hear from folks who are experiencing some, health disparities and some challenges based on some of their vulnerabilities, but also how we can help support them. So I hope this will be a helpful video. It's just about 5 minutes, and then we'll pick back up with our presentation.
The world has got to change. I lived in a community that was so prosperous with doctors and lawyers and politicians. Now we have drug dealers and corner stores that they don't sell anything but the wrong things. You cannot deny the impact that it has on people's health. I have been in West Baltimore my entire life. As far as money, my mother didn't have any money. I don't want to say she was poor, I'll say low income. Poor we were though. In the 50s, we didn't have many choices as far as healthcare. The healthcare system then was limited. It was not good for us. And medicine costing so much that my family says sometimes, will I eat or will I pay for my medicine? Oh, I just love my daughters when they come over and we get together and we cook and prepare meals together. It's healthy meals. When my oldest went to college, she came back with a different diet.
Now what happens is if I do a meatloaf, it's turkey instead of ground beef. I make spaghetti, I make chili, stuff like that. It's with turkey and chicken. We grew up, we ate pork. We ate bacon, we ate a fresh shoulder, we ate pork chops. I did not think it was not healthy eating, right? Because this is what we were accustomed to. I was in denial. I didn't want to face the fact that I was becoming a diabetic.
The impact is the fact that my family ended up with heart disease, emphysema, diabetes, cancer. My mother's sister, her daughter died of diabetes. She was an amputee. My mother died of a massive heart attack. And
to address health disparities, we need to understand why they exist, that they're not due to one single factor. They're the result of policy decisions we make as a society. They're due to the environment, health education, insurance and access to care, access to healthy food, and stress. Those stresses are actually experienced disproportionately by people who are poor and people who have been historically disadvantaged in this society.
Solutions to these problems cannot just be medical, it's systemic. And that means everybody has to get involved.
If we want a nation to be strong, the people in that nation have to be healthy. They have to be well. If there's anything that we can do to stamp out disparities, we need to do it by any means necessary.
Hi, Ms. Simmons.
Here at East Baltimore Medical Center, most of the patients are underserved.
We need nice deep breaths in and out through your mouth.
Michelle is a terrific success story. There was actually a year where she had lost her job, and before she found a new one, she had no health insurance. And she still managed to buy her medicines out of pocket, paid out of pocket to come and have doctor visits. She was really invested in her own health. That's something that Dr. Cooper's research is looking at, why patients don't invest in their health like we wish they would.
The next thing on the agenda is the community update. So I'm going to
Michelle joined our community advisory board in 2011. We provide education to the community about health and about research. We offer training programs for community health workers. We can be sure that we are meeting the needs of people appropriately and that we're not leaving out certain groups of people that have traditionally not been included in conversations related to health and healthcare. Our strong relationship with the community is just essential. There's no way that we could do what we're doing without their input. And my work is just one of many initiatives here at Hopkins.
Ms. Simmons is a great example of what happens when we get it right as clinicians and as an institution.
I am a fighter. I am a believer. I stand for what's right. And what's right is people's health. And I will never give up as long as I have breath in my body.
One of the things that is so important is that people have what I call a liberated future. And it's hard to be liberated when you're not healthy. When I say liberated, I mean freedom to be all that God meant for you to be. When we don't deal with disparities, and what we're doing is denying people an opportunity to give back to the world. So we've got to fight it. We've got to fight it with everything we've got.
All right. I hope that that was helpful. I think that Michelle's story is really so representative of what I hear from many of the patients that I work with. And certainly over, my years of, 12 years of being a nurse and really looking at what people need to be healthy. Health is foundational to everything. Like we were just saying at the end of that video, without health, we really do have difficulty in every other area of our lives. And so to be able to advocate for health and to give people access to health without those disparities and to ensure that equity is there, I think that is just foundational to what we do in the US and in our healthcare system. Someone said that they're so glad that they changed their eating habits. Yes, eating habits are so important. We're going to talk a little bit more about that as we go through. Social determinants of health are really some of the things that we've been talking around, and many of you probably are aware of these. You may or may not have known that they were called the social determinants of health, but it's things like that economic stability, your neighborhood and your physical environment, both in your home and in your community, education levels, food and access to healthy options, because we do have things like food deserts. We talk a lot about food deserts, but how often do we talk about food swamps? I don't know how many of you are familiar, but with food swamps, it looks at how many restaurants, like fast food places, that are going to have those dollar menus that are going to be easier for people, especially with young children, to be able to buy those dollar menu items, and they're overrun with those types of restaurants, or maybe it's convenience stores or things like that, where they're having to buy their groceries because they don't have a lot of access to anything else. Those are considered food swamps in the sense that there are so many options for those fast food options, but there aren't healthy options. If you don't live within 20 minutes drive time of a healthy, full functioning grocery store, you're considered to be in a food desert. But you could also be in a food swamp simultaneously because you've got things that just are convenience store, fast food level options that maybe you're at the Dollar General or you're at the McDonald's or Taco Bell menu, and you're not seeing those healthier options in communities that are lower on the socioeconomic status, or maybe or that are rural, so that they're not close by to these big areas. And so that's an important component too. The community and social context, how much support is in the community, how much stress is there, what are some environmental concerns, healthcare system, do you have a hospital with an emergency room within 20 minutes? Again, 20 minutes is usually the metric for kind of the reasonable time to drive somewhere. And then our health outcomes are impacted by this: our mortality, our morbidity, how long we live, our healthcare expenditures, so how much we're spending on our healthcare out of pocket, our health status, and just the functional limitations of the things we've mentioned. And there's so much more, of course, that goes into this. There's stigma, there's bias, there's discrimination, there is implicit and explicit bias. And then there's, generational trauma. There's lack of generational wealth in some groups. There's just so much that we could go into here, but really this is just a conversation to spark, hopefully, an even more important and detailed conversation in your own communities and your own spheres of influence, where we can advocate for ourselves and advocate for others. So these are some important things to consider. Social determinants of health are going to be the foundation for looking at where health disparities and health equity need to be addressed. So understanding poor health outcomes, it's not just that we are from a certain group and so that group has more of a likelihood to be sick or to have this issue. It's not just about genetics, and it's not just about our health beliefs and our health behaviors, right? It's a combination of all of those things working together. So it's not that it's one or the other, it's usually and both, right? It's all of it. And so genetics do play a factor. People like to put a percentage on that, and I don't know that you really can put a percentage on how much genetics and environment play a factor. We've always had that nature versus nurture conversation of, what's more important, and I think it depends on the person. And I think it depends on the particular situation. And so I'm not going to tell you, that 80% is environment and health behaviors and 20% is genetics. That's what you hear a lot of. But, I don't know that we have the support to show that right now, and certainly not as a blanket statement. Both play an important role. So control what you can control. I always tell people, that is the most important thing, is recognize where you have control what you can control, and then the rest, you just have to do the best that you can. Socioeconomic status, education, access to healthcare, access to education, access to community resources, cultural norms, really telling people. A colleague shared one time that she was working in a big city with a Hispanic population that really was struggling with healthy food habits. And her colleagues were telling the folks in the clinic to stop eating tortillas. And, and she said, when I came to work there, I really had to think about, is that realistic to tell this group of folks not to eat tortillas when that's really foundational to what they eat? And they tend to eat those daily, at least in the clinic where she was working. And so she was like, I don't think that is the best option to say, no tortillas. It's how can we make these tortillas healthier? Is corn healthier than flour? Can you make them at home versus buying them? Can you make them free of enriched, flour so that, you process that easier? Is there a gluten sensitivity? Can you make them without gluten? Is there a substitute? So how can we make that thing healthier versus saying that we just need to eliminate it altogether? That's really how you can help respect cultural norms and help set those folks up for success, because that is something that's an important part. We have this notion that food is fuel. That has been what we've been saying for a while now, that food is just fuel, and you just need to eat, count your calories, and you're good. Well, the thing is that food is more than fuel to me. I don't know about y'all. You're welcome to put this in the chat, but I'm a Tuscaloosa native and grew up with great food, right? And food is cultural, food is celebratory. Food is fuel. We need it to survive, but it's much more than that. And so I think to just say that it's calories in, calories out, move your body, that is not really health, right? The health is so much more than that, and it's more holistic than that. And counting our chemicals, counting the preservatives, the additives, and the chemicals in our food is as important as counting the calories. So sometimes more so. A lot of times we're eating very calorie dense, but nutrient deficient food, like in those dollar menu examples. And so the calories may not actually be, that kind of, damaging to your health. It may be the chemicals there, and it may be the fact that you're eating small portions of calorie dense food that doesn't have a lot of nutritional value. And that's why you're staying hungry, and that's why you're having cravings. And then our implicit bias, explicit bias is where we intentionally are acting on our bias or our prejudice. And implicit, which we all have implicit bias, that is the more kind of subconscious or unconscious bias that we have. And that's really where we want to focus our attention, because the ones that we know that we have, we can address those more fully. But when we have the implicit bias, it's a little harder. Harvard University actually has an implicit bias module that's free online that you can go to with a quick Google search. And you can take the test to really look at your level of implicit bias and where that might show up for you. And I really encourage that. That's something that we do with our Committee on Inclusivity here at the College of Nursing that looks at DEIB, so diversity, equity, inclusion, and belonging. And it's a privilege to get to serve on that committee and to be the chair right now. And so that's something that we really look at in healthcare because it's important to our patients. So minority health disparities, when we look at health equity, it really means that everyone has a fair and just opportunity to be healthier. And so when the doctor on the video was talking about, we want to know why people are not investing in their health the way that we want them to. It's likely because they don't have the opportunity to invest, right? If you have to make the choice between feeding your family and buying a prescription, then you're probably going to feed your family. You're not going to spend money on that prescription. If you lose your job and you're trying to, pay your rent or your mortgage, you're going to prioritize your rent and your mortgage over that prescription or over that doctor's appointment. That just makes sense. And that's something that unfortunately, fortunately, but unfortunately, so many healthcare providers come from a place of socioeconomic privilege that they've never been in a position where they've had to choose between having health insurance and a health visit and being able to pay their mortgage and feed their family. So that's something that I think is really important to consider. I've had a difficult time in my life. I did not always grow up with socioeconomic privilege. I'm a first generation college graduate. And so there have been times in my adult life where, as a mother of young children, I was without health insurance and my children were without health insurance. And I had to make hard choices about, how to allocate my money. And so although I'm in a really good place now, and I'm very thankful for that, there have been moments in my life where I've had to make some of these choices. And, even since having become a nurse. And so those are some things that I think if we're not intimately familiar, if we've not experienced it, it's hard for us to imagine why our patients or clients or whomever we're talking about might have to make those hard choices. So this is really about requiring the removal of obstacles to health, and that's poverty, discrimination, and the consequences of discrimination, the feeling of powerlessness. There's a lot that we talk about in, I have a political science background, graduated with that degree before going back to nursing school. And so we talk about political self-efficacy and how that really is impacted if you're the target or if you're a vulnerable population that experiences discrimination, how you're not going to really utilize your political efficacy. You're not going to have that confidence to make those decisions. Well, that's the same with health. You're not going to have that self-efficacy to be able to advocate for your health if you're in a position where you're struggling to make ends meet. And the lack of access to good paying jobs with fair pay, with quality education, with housing, with safe environments. We know that certain areas of town are more likely to have environmental exposures and toxins, and then the lack of easy, accessible healthcare that's going to really meet the need. So even as we think of health equity as the outcome, we know that health and well-being are nurtured, protected, and preserved where people live, learn, work, and play. And so it's important that not only do we provide these wonderful opportunities in our community, but that we provide them to all communities. That folks should not have to leave their home. They shouldn't have to drive more than 20 minutes outside of their home area, their neighborhood, to be able to get good access to care. And we know here in Alabama that, one metric we look at is how far does an expectant mother have to travel to be able to give birth to her baby. And that's about an hour and 15 minutes if you look at how many rural hospitals have closed or how many rural hospitals no longer offer women's health and women's health services. Folks in Alabama are having to drive an hour and 15 minutes on average to be able to deliver at a hospital. So that is definitely something that we need to work on. And it's one metric where we know that if that's the standard in our state, then there are many other things that people are having to drive that long for. And that is something that can impact our health outcomes. Common health concerns that we see, kind of challenges with specific groups having, access issues or having medications or treatments that need to be altered to be able to meet their specific need would be heart disease and cholesterol and triglycerides. Again, that's going to be genetics, environment, health behaviors, diabetes as well, hypertension, stroke, cancer, obesity, especially now that we're seeing childhood obesity rates on the rise, depression, anxiety, and stress, and really all mental health is impacted, particularly the metabolism of certain medications, sexual health, and environmental exposures. So these are common health concerns that we see that can be impacted by some of our, lack of awareness around diversity and how things are needing to be addressed at a bio-individual level. So other specific health concerns that I see, metabolism of pharmacokinetics, the pharmaceuticals, that can be a challenge because we metabolize medication differently. We know that hormones play a factor. So, when we look at gender or sex, that can play a factor in that metabolism. Certainly different groups because of genetics and just different, environmental exposures can cause the metabolism of the pharmaceuticals or medications to be different. We have things like sickle cell anemia that you usually see with people with African or Mediterranean descent. You have things like vitamin deficiencies, respiratory disease, asthma, pain management is huge because there are a lot of times very outdated and very biased and prejudiced research and teaching that pain management is different across groups. So one common one that you hear is that people who have darker skin tones or who may have African American descent may tolerate pain, may have a higher pain tolerance than others. And we know that that is a blanket statement. That is not true for everyone, but that's still being taught in some schools of nursing and some medical schools. And so that's something that's hugely important to say. Pain management is very individual. That the way that we express pain is very much based on our core values, our beliefs, our culture, our family of origin, and that pain is what the patient says it is. And so if the patient says that they're in pain, we've got to treat that pain. If we're concerned with, over medication or things like that, then we need to reach out to that healthcare provider who's writing the prescription. Sun exposure, that's another myth that if you have, darker skin, that you're going to be less likely to develop melanoma or other skin cancers. And so sometimes folks who do have darker skin tones or who don't burn easily won't wear sunscreen or won't do the things to protect their skin, like staying out of, doors, in the really hot times during that 10 to 3 or 10 to 2 time frame in the summer where it's the most hot, the most direct sun. Not wearing protective clothing or protective eyewear in the form of sunglasses and hats and SPF clothing, because there has been this myth, and we have seen it over and over again in the medical world, taught to students and nursing students, doctors, that you don't have to wear sunscreen if you're darker skinned, and we know that that's not true. Unfortunately, everyone can get skin cancer and everyone can develop melanoma. And so it's really important to be looking at your moles and doing those good skin checks and making sure that you don't have any concerns there. And usually when you're looking, you want to make sure that you're looking in areas that don't always get the sunlight. In my experience, and again, I'm just one perspective, I've seen a lot of melanoma places be in the areas that you're not getting as much sun, that you're not getting repetitive sunburns, but maybe you had one really bad sunburn because that is skin that doesn't get as much sun. That has been true for me and for my family. We have a long history of melanoma, and I've had precancer melanoma, and the places that I've had those spots have not been the places that you would kind of logically think. So those are some things to really consider. There's certainly many more, but we just want to really bring attention to this is not one size fits all, and it's really important that we have these conversations in our communities and with our friends and with our sphere of influence. And certainly we're doing what we can to really start to change that narrative within our education. We do a great job of that here at CCN and at UA, and we're really wanting to be leaders in that in our healthcare communities and education. So screening and prevention is really the key to healthy living, and it's so important regardless of any of the demographics or diversity or any of the things that may set you apart as unique. That you're getting a physical exam every year and that you're going when you're not sick. Sometimes we only go to get a checkup when we're not feeling well. And that's not the best time to go, because you really want to go see a healthcare provider when you're at your baseline so that you can get good baseline numbers. We always say know your numbers. So they want to be able to screen for medical issues, assess your future risk of medical issues, encouraging healthy lifestyle choices and really looking at that based on the concerns that you may have, updating any immunizations, and helping you build a relationship with your PCP or your primary care provider. And that could be, a nurse practitioner, that could be a medical doctor, a naturopath, that could be a physician's associate. And so we really want you to have a relationship with your primary care provider and to have what we now call a medical home, so that if you do have things that come up, like with COVID, you're going to someone who knows you and knows your family and knows where you work and what you're at risk for, so that you're not relying on emergency care where those folks may not know you as well. It just helps give you personalized care. Healthcare recommendations, these are the things that we think everyone should get checked for. So the annual physical with lab work, and I say comprehensive lab work, a dental exam and cleaning, you want to do that twice a year. Hearing screens, once we leave K through 12 system, we usually don't have a hearing screen unless we have a problem. But I think as we start to age, it's really important to have those hearing screens. You may be hearing fine, but there are other things that can be screened for, like auditory processing disorder is a really common disorder where you have difficulty hearing if there's a lot of background noise, but you may test as having perfect hearing. But there are special tests that you can actually do to have that auditory processing to be captured. That can be life-changing for folks. People who have a diagnosis of autism, like my son, or people who have ADHD, there are some common correlations there with those folks also having some auditory processing disorder because of the way that's coded on certain genes. And so those are some things to think about. Having a hearing screen, especially if you're at risk for hearing loss. Age-related hearing loss is common, but that doesn't mean that it's quote unquote normal. So kind of getting away from that, just because it's common doesn't mean it's normal. I'm really a huge fan of promoting that. A comprehensive eye exam, which means that they dilate your pupils during the exam. So you may see an optometrist for your reading glasses, and I think that's really important, and that's a great utilization of your resources because they're usually easier to see in terms of getting an appointment, and usually it's a little bit less expensive. But I do think as we start to age, it's important to get that pupil dilation. Usually every year to 2 years, your ophthalmologist would tell you based on your experience, unless you have risk factors, high pressure in your eyes, like indicating glaucoma or something like that, you may actually get pushed out to 2 years. But the standard is to have one every year. Blood pressure screenings are so important, especially if you have a high rating. We sometimes are not diagnosing folks with high blood pressure and hypertension now because we're trying to factor in the white coat syndrome, meaning that your blood pressure is high because you're getting it checked and you're at a healthcare office. That's why it's so important to be able to utilize the health screenings here at Wellbama that we offer, because maybe it's a little less pressure. We also have a blood pressure machine that you can use over on the Flint Road campus, and also in the Ferguson, or the Student Center now, that you can actually check your blood pressure and do that just like you're at a pharmacy or a grocery store. And so that can give you an accurate reading. But 3 readings that are in the high blood pressure zone are going to probably indicate that you have hypertension and you may need treatment. So that's something to consider. High cholesterol is something that's really important, especially for people who do have some, risk factors. Cholesterol, diabetes, high blood pressure all go hand in hand with something called metabolic syndrome. We have a cardiovascular talk that if you're interested in this, we have that as an archived talk on wellness.ua.edu, and you can go to that webinar section and you can watch that if you're interested. I think it's some really good information. It's one of my favorite classes to teach because we talk about a lot of myths and the connections between blood pressure, cholesterol, diabetes, heart, stroke, cancer, all goes back to inflammation. And then a baseline EKG for some folks is important. Certainly not everyone is going to get this every year, but for those who are at risk or who have any kind of underlying conditions like mitral valve prolapse or things like that, that could be important. And getting your thyroid checked is really, really important. For me, I think it's one of the most overlooked because when you think about thyroid, you think that you're going to have a lot of signs and symptoms. So, hair falling out and feeling tired and sluggish, but it can be much more, kind of subversive. It's not always really evident at the beginning. It could look like low mood or depression. It could look like anxiety. It could be, feeling extra tired. And certainly when we're sick or when we're dealing with, any kind of other illness or stress, your thyroid's going to take a little bit of a hit because it's really the engine of our bodies. And so having your thyroid actually palpated and your blood levels checked, I think is important, especially as we age. Women are more likely because of the autoimmune connection to have thyroid issues, particularly hypothyroidism after a pregnancy, particularly a stressful pregnancy, a twin or multiple pregnancy. You're more likely to have some thyroid issues. Doesn't mean that you're always going to have thyroid issues, but you may need a little support when you're overcoming some of those obstacles. So getting that palpated is super important. Some other things, of course, immunizations, your flu, your tetanus, your pneumococcal, your hepatitis, all of those standard immunizations that require boosters. Of course, with COVID, it's important to have an understanding of what your risk factors are and for you to make that decision about your COVID-19 immunizations and boosters. So follow the CDC guidelines and the advice of your healthcare provider. A colorectal cancer screening, we've now seen that people are starting to recommend this at age 45. So age 45 for everyone, because we're seeing research now that shows that this is on the rise. And so, for most people in textbooks, they're going to say age 50 unless there's risk factors, but we're seeing more and more people advocate for age 45 regardless. And so that would be my recommendation. Colonoscopies every 10 years or as needed based on your provider's, recommendations. You can even do things like fecal occult blood test and the fecal immunochemical test, which could also be something that you do instead of the colonoscopy if your screenings are not indicating a high risk. So those are kind of important. Even things like your prostate exam for male clients, breast exams, those are all things that you're going to want to include as well. And those are things that we talk more about in Your Health Over 40. And so if you're interested in that, definitely take a look. For breast cancer, I do want to say, especially for women of color and young women, you're more likely to have, based on research, our statistics show more aggressive forms. And so doing a monthly self-breast exam is really important, especially going up all the way under your armpit, or what we call the axilla, because a lot of times, especially young women, and this is regardless of color, tend to have more of that inflammatory breast cancer, which is going to be more under the arm. And you have breast tissue all the way up under your armpit and on your side, not just in the breast itself. And then certainly we know that men can have breast cancer too. And certainly we need to be aware of that. So, doing those self-breast exams, particularly after your cycle is over, if you still have a period, that's an important thing to work in. So maybe you pick, your birth date or, a certain time of the month, and then you just always know that that's important for you to check. So some other special considerations, really addressing policy and cultural changes are needed. health disparities, outdated medical education, which we've mentioned, false beliefs about biological and physiological racial differences, environmental and sociocultural health effects, and just these innate health differences that we have because of that bio-individuality. And then working on our implicit bias as healthcare professionals is so important, especially in the way that we teach the new generation. And so having this conversation is important. The policy and changes that we need to see are really going to be at the level where we start having training, and that training is required for you to be a practitioner. I think that's really important, and we're headed there. I think that's something that's going to be coming out in the next few years, because we see how important it is to understand not only the biological process of what it means to be healthy, but also what makes us unique and what makes us special, and to celebrate that. So health equity then is defined as the absence of unfair and avoidable or remediable differences in health among social groups. It's about values of fairness and justice. It's about valuing health as being essential, and it's about representing health and the important public good. So there's just so much that goes into that. See the chat, I'm going to check. Yes, this recording will be available. And I also have an older recording where one of my colleagues, Dr. Johnny Tice, he has moved on to another step in his career. So he's no longer at the university, but he and I did a talk, and we co-taught this content a couple of years ago, and it's still available on the archived webinar. It's also really good because he offers a different, unique perspective. So I would highly encourage you to go back and watch that one as well. And then barriers to health equity, we've talked about it, but just the lack of availability and access, the lack of understanding that some healthcare providers have, transportation issues, that can be hugely, hugely detrimental. Just as an example, I usually don't share so many personal examples, but my husband and I have been a one-income, one-car family for many years. And so transportation for me to be at work, for him to be able to go to his doctor's appointments, because he does have type 2 diabetes and a number of other health problems. He's had cancer and things like that. And he likes for me to share this so that other people benefit. But those have been some challenging times of having that one car and being able to get him to his doctor's appointments and things. And so it's a very real issue, especially for people in rural areas. Maybe they don't have reliable transportation to drive an hour and 15 minutes, or maybe they vehicle share. Especially our older folks who may not be able to drive any longer, having to rely on others to get them to their appointments can be very hard. That's where telemedicine and telehealth can really be helpful. I hope that that's the silver lining of COVID, is that we've learned how to do that well, and we can give that access to other folks who are out of our reach. But we've got to have that good internet access, and we know that the state of Alabama doesn't have good, reliable internet access in all areas in our rural communities. And the belief that health treatments doesn't work. So many people think that it doesn't matter. That their diagnosis is inevitable, it's not reversible, and we know that that's not true. So giving people hope is important. A health system that really looks at the values and cultural norms of others outside of just the standard societal values and norms. Looking at racism, bias, and discrimination and how we treat folks, our language barriers, our insufficient number of non-native English speakers who can act as translators for our patients, health literacy, and then the lack of adequate health insurance coverage. Even with the Affordable Care Act, we still have people who now they may not be uninsured, but they're underinsured. And the latest statistics that I pulled, health cost and health care issues in terms of finances are going to be the number one reason for people filing bankruptcy in the US. And so that's an important consideration that impacts our relationships. They've even had some research that shows that impacts divorce rates. And so it's something to really think about and consider. So steps toward health equity: providing interpreter services, recruiting and retaining people who are representative of the communities where you work. So representative staff, providing training to increase our awareness and our knowledge and our skills around cultural differences, and how to best be, have that humility, coordinating traditional healers and community leaders, using community health workers, so having community-based care for the folks in their community, incorporating culture-specific attitudes and values in our health promotion tools. So helping people to make healthy tortillas, not telling them they can't have tortillas, including family and community members in the healthcare decision-making. So, of course, at the discretion of the patient, locating clinics in geographic areas that are easily accessible for vulnerable populations that really meet the needs there, where they're not having to go there and somewhere else. That's really important. Expanding our hours of operations, because we so often forget that there are a lot of people who don't have off days. They don't have PTO. They don't have sick leave. So if they're not at work, they're not getting paid. If the weather's bad, they're not getting paid. So think about, our construction workers, housekeeping, those folks out in the community who, if they're hourly workers and they're not working, they're not getting paid, and they're going to need to have options later in the day. And they may be working more than one job. So they may be working an 8 or 12-hour shift. So we've got to get really creative about that. And then providing linguistic and cultural competency that's not just at the clinical encounter, but at the appointment desk, at the help or on-call, phone lines, at the billing, at the area where you're getting written materials and education, that we really are providing that. And then health literacy, we've talked a lot about this, but these are just some facts and figures to support what I said about it's really the degree to which people can actually understand basic health information and services in order to make appropriate medical decisions. And y'all know why it's important. But people of all ages, races, income, education levels are impacted, and disproportionately so in our socioeconomic and minority groups. So really, really important to think about. And then the Toolkit of Resources, healthy habits are important. I have a lot of information that is on the archive site in terms of how to, engage in regular physical activity. The foundations of health are really going to be the wellness basics that I teach about. There's this class specific to that, and that's drinking about half of your body weight in ounces of water a day, but usually no more than 100 to 128 ounces. Getting good quality sleep, not just, quantity, but quality of sleep. Exercising to move your body. That doesn't mean that you have a fancy gym membership. That just means that you move your body in a meaningful way, about 30 minutes, 4 to 5 times a week, that you're giving your brain a break, meditation, rest, that you're taking breaks regularly throughout the day. I say 5 to 15 minutes in the morning, afternoon, and evening. And then, that you're really eating nutrient dense food, that you're not just counting calories, but you're looking at chemicals, and that you're eating food that's healthy and supportive of you. So those are the 5 wellness basics. Things like smoking cessation, not using tobacco products or other things, exploring your family history and knowing your numbers so that you can have healthy goals. Well, BAMA screenings help meet many of these. And so that's a free benefit for you as a UA employee. So we really encourage you to encourage others, because y'all are likely doing these things already, but encourage the folks in your departments to come and take advantage of these resources. And we even pay you to do them. So a lot of the programs and things, you can get $50 Visa gift cards that you can spend anywhere, and that's amazing. So these are some of the things that we can monitor through the WellBAMA screenings. And of course, we make referrals and tell you to follow up with your provider if we see anything of concern. We also have things like yoga and other programming. So this is a yoga on the lawn. And so this is going to be out in front of the HR administration building. There's more information on our wellness.ua.edu site. You also can sign up for the newsletter that typically comes out monthly with these types of programming announcements. But we want you to feel encouraged and empowered to not only participate, but to share with your friends and colleagues on campus. Things that you might want to consider: Verta Health is a new program. I have 3 slides on this, but essentially it talks about, and I'll go ahead and switch to the 3rd slide, how you can help reverse type 2 diabetes. And if not reverse it, at least, have a more manageable medication regimen. This is for people who are on insulin and who are on orals. So it's not just, if you're on oral medication. Like I mentioned, my husband has had a long history with diabetes, and he has just signed up for the program. He actually went and got his blood work done today, and it's been a really good process. And so it's been very user friendly. He's not needed a lot of help with that. And so he's been able to walk through the process just by giving them a call and them doing the intake. And I asked if it was okay for me to share that with you, because sometimes I think you need to hear from others that it's a really, easy, accessible process. In diabetes, when you start to address issues with diabetes, you're addressing so many other health concerns because you're working on your food and your water intake, and you're also working on your inflammation. And inflammation, like I alluded to earlier, is really at the root of most of our chronic health conditions. And so you're only going to qualify for this if you're pre-diabetic or diabetes type 2, but I think it's a really important service, and let your colleagues know about this. This also works for their dependents. So if they have the health insurance program, like my husband doesn't work here at UA, but he is my dependent, so he is actually able to participate. So it's a really, really great benefit. And this is another slide for that. So helps reverse type 2 and prediabetes, helps you lose weight, eliminate diabetes medications is the ultimate goal, and reducing your A1C. And they actually work with your provider who's managing that for you. So that's really, really neat. Such a great program. Additional resources. April is Minority Health Month, and so I think that's why it's so important to have this class during the month of April. We've got the Department of Health and Human Services that offers information on minority health, and then Alabama Together, which is building equity so everyone wins. And really, one of my favorite quotes by my favorite president, John F. Kennedy, said, a rising tide lifts all boats. And so when we help others, we help ourselves. And I think that's so important to really take care of our neighbors well. So our final thoughts is just educate, empower, and encourage. And I hope that this has been educational and empowering and encouraging to you. I know we're at our time, so if you need to go, I completely understand. Thank you again for if you had to make a change in your schedule to be here. Thank you for that. I really appreciate your flexibility. And I'm happy to take any questions, or if you have comments, if you have topics you would like to see me add. I really, really covet your feedback on this class, because I think it's just a really unique class that we really want to continue to add to and make this continue to be relevant and meaningful for y'all. So feedback or comments or questions are welcome. And Miranda has linked the What Wellness archived webinars, and she's also put in the PowerPoint. So if you can and you want the PowerPoint, you can go to the chat and you can download it from there. Thank y'all so much for the comments. And I'll hang on for a few more minutes. Okay, if you were unable to download it, if you can email me or if you can email Miranda, we can get that to you, no problem. I'm glad this was helpful. Thank you for the kind words. Let me go to this last page. That will give you my email address. Thank y'all so much. Well, I hope that y'all have a wonderful rest of your day. And if I can ever be of help to you, or if you have feedback or questions that you'd rather email me directly, you're welcome to. It's abby.horton@ua.edu. And I'm more than happy to help you or to take your comments or feedback, because I think this is a class that is really important. It's really special to my heart. And it's one that we really need to make sure that we're offering and promoting and helping those who are interested in this. So thanks for the good work that you're doing. I hope you'll have a great rest of your day, and we'll sign off with a big roll tide. Bye, y'all.